If you could mute your device that you're joining from. I think we have one person with some sound in the background. Thank you for muting. I appreciate it. We have our guest host today is Dr. Diana Bitner. And I will introduce her a little bit more, but I also want to say thank you to our sponsor for tonight's event. Tonight's sponsor is Maria Tornga of Boss Lady Realty. And she has a special right now. I don't know if you caught it in the newsletter or not, but her special is that she will do a free appraisal of your home if you're looking to sell, a virtual appraisal. So you're welcome to reach out to her, and she's good with Facebook Messenger. So Maria Tornga, we can put that in the chat too. You guys can reach out to her. Her goal for being our sponsor this month was at least one new person reaching out to her. So I think that's a pretty great goal. So if you guys are in the market for selling your house or considering it or would love to know what your home appraises for, reach out to Maria Tornga. So after all of that, Dr. Diana, welcome. We're so excited to have you. I'm thrilled. And I should probably tell everyone, after meeting you one time, I signed up to be a patient. So I've already filled out my information with True Women's Health, and I am on board and ready to go. So
awesome. That's the highest compliment.
One meeting, and doctors make me nervous. So it says a lot. So if you would like to get started introducing yourself, Dr. Diana, you are an OBGYN under a different practice. I'm just going to ask everyone to mute real quick. Oh, thank you. Awesome. We're good. You were an OBGYN for 25 years under a different practice, and now you've started your own practice. So just tell us a little bit more. And we also have a PowerPoint for everyone to view at the same time, but we'd love to hear from you.
Thank you. And will the PowerPoint be up somewhere just to keep me organized? I sometimes get
we can start that now if you'd like to start it.
Okay, we might as well, just that'll keep me on task. But and again, everyone, thank you so much for having me. I'm so pleased to be here to be able to share this information and share a bit about my story and how I hope I can help everyone. So if you would go to the next slide, basically I want to talk about my why, and that starts with, who am I and what do I do? So I'm an OBGYN, and I've practiced in West Michigan for over 25 years. I grew up in Grand Haven and finished residency in OBGYN at Butterworth Hospital. And I changed practices because, the whole story started about 15 years ago. So I'm delivering babies, doing surgery, loving my practice, loving my life. I've got 3 little kids, married, busy, but women started asking me questions that I couldn't understand, that I didn't know the answer to. So people started asking me, why am I gaining weight? Why am I having hot flashes? Why don't I want to have sex? Why does sex hurt? Why am I having headaches before my period? Why, all these things that I didn't feel comfortable answering. And so I felt like, I'm an OB doc. I really should be able to understand and to be able to help women through this. So Rhiannon, that's how I got started in this, by going to a women's health meeting. And I was just blown away about how much information is out there and what is available for us to really help ourselves get through aging.
And when we talked on Saturday, I remember you mentioned you just didn't really feel that you had all the tools you needed to help educate women in their journeys through their hormones, or as they're aging, as their bodies are changing. And I think that's amazing that you took ownership and took everything in by the reins, right? And just started this new practice. So I'm excited.
Well, I joke that as doctors are like men, sorry to the guys out there, but I'm we like to fix stuff. And so as a physician, if you ask me a question and I can't fix it, it makes me feel inadequate. So, somewhat selfishly, this was about me. I wanted to be able to help you all, but I was thinking, if I don't know the answers to these questions, how are you supposed to know the answers as a non-physician? Like, this knowledge, it's not rocket science. We all deserve to know about our bodies. And so I thought, I've got to learn this so I can pass this information on. And it's just been an evolution over the last 15 years or so to really figure out what is that knowledge, and then how do I communicate that back to my patients. That's where all of this started. It is sitting in the back of a women's health meeting and saying, there is so much great information here. I've got to bring this back to West Michigan. How do I do that?
Right.
So that's how this all started.
All right. So do we have your next slide then? We're go into the next portion here.
So thanks. So women's health, I really feel like women's health starts with you. This is not about me. This is not about the health system. This is not about, it's so important that we make women's health about you and about what each woman wants. I was looking at even just my book, and in the front of the book, I wrote the dedication to the wise woman in each of us who is working to discover her true self and live to her full potential. So to me, that's what this is all about. It's thinking about how we picture ourselves. And I don't know about you all, but I remember being in high school and thinking about, I've got my life in front of me. I'd like to think that the possibilities are endless. And, then for so many of us, life kind of happens. Things happen maybe out of our control. We make choices that some are good, some aren't so good. And so all of a sudden things happen. And I've had so many patients end up at 45, 50, 55, 60, 70 and say, I did not expect or want my life to turn out this way. And so I really want women to get back to, no matter how old you are, no matter where you are, and say to yourself, how do I want to be? What do I want to be when I grow up? And I'm a very visual person. And so I think about pictures. I think in pictures. And so when I came up with this, I wanted women to think about, what is your picture of self at a milestone event? It's an event that's going to happen. So for me, forever, it was my son's high school graduation. I could picture the graduation party, and this was 2 years ago. So I could picture the party. I could picture myself at that event, and using sort of the way that I think about wellness. How active am I going to be at that time? What is my weight going to be? What is my muscle mass going to be? What is my fitness going to be? Do I want to have cancer? No. Do I want to have diabetes? No. Do I want to? So I went through each part of wellness to think about, how do I want to be at that event? And I really used that goal, that vision of myself to get me through some good times, some bad times, but to really keep me on track for what that event would look like. And when that event finally came, it wasn't perfect exactly how I pictured in every area, but I had a sense and I had a plan, and it really helped me feel like, wow, I've arrived at this event. And then I set another event, and then I set another event. So I want you all to think about a milestone event that is going to happen. I don't care if it's a birthday, if it's Christmas, if it's 4th of July. I had a lady last week who set July 4th as her milestone event, because last year, July 4th, of course, in the middle of COVID, when it was still more than it is now, even in terms of us figuring out what we're doing with our lives. But she normally has a big family party every July 4th, and she loves it. She lives for it. She cooks, she plans, she hosts. Last July 4th, she was hiding in her closet and just didn't even want to participate. So we set this next July 4th as her milestone event. So everything she's doing, everything around her is around that event. And I think about this patient, we'll call her Kathy. She was one of my aha moment patients, in the sense of, years ago, this is maybe again 14, 15 years ago, when I just started to think about this stuff. I was running through the office. It was a busy day. I'm going from room to room, and we come around the corner together, and we almost run into each other. And I just kind of looked at her and said, excuse me. And I was moving on. She said, wait, you don't remember me, do you? I'm like, kind of. And she said, well, last year you asked me a question. Do you remember what that was? And I thought, no. And she said, it was my annual exam. And you asked me, how do you want to be next year at your annual exam? And she was also going to be turning 50. How do you want to be? And she said, I didn't really answer you at the time. And we kind of, got my pap smear done and stuff, and I was off. And she said, I really thought about that. And I decided that I wanted to be hot for my 50th birthday. And she said, I really had to think about what that meant to me. And it meant to me that I could run a 10K. I could fit into my size 8 jeans again. So she really defined that in her mind, what that picture of self was for that event. And she said, having the vision of my 50th birthday and having you ask me that question, it got her through a difficult relationship. It got her through a difficult job transition. And she went for a run if she was tired or not. She ate better if she wanted to or not. She backed off on her alcohol. It really was that vision of herself. And I thought, wow, there's a lot of power in that. So I would ask all of you, as we talk tonight, to really think about what is your why and what do you want to be at that milestone event?
That's good.
All right, next slide.
If we don't set that goal, Dr. Diana, then we have nothing to aspire to, right? As I feel like I can speak to now being a patient of yours, you created an app for your patients to utilize. And in that app is goal setting. Right within the app, you're able to walk through different points of setting goals. And it's super helpful, and it connects to the data that's already in my phone.
Thank you. And what I so love is that when people fill out that intake form, it's a little lengthy, as you found out, but people say, I never really thought about aging as a choice. Like it was just kind of happening, and I was kind of reacting to it. And even the questions, and that was very intentional, of course, but I think by asking the right questions, sometimes, that's the best treatment, because we're all smart. We're all very capable. It's just sometimes we don't have the information and we don't have the language around that kind of thing. On the first slide, I said something about, why True? And, one of the reasons I started True is I wanted to be able to do things like create an app. I wanted to use this novel approach to healthcare. I wanted to be able to offer longer appointments, which just doesn't work in a regular hospital system. I mean, a hospital system does sick really well. They do sick care really well. If I'm sick, I know where I'm going. My son had his appendicitis on New Year's Eve. We got excellent care. But in terms of doing well care or wellness care or prevention care, I love that quote from Albert Einstein. I'm going to paraphrase. We can't fix old problems with old solutions. We have to have new solutions. And so at True, we're really trying to we are building this novel way that promotes women being back in the driver's seat of their own healthcare. I tell my patients, the last patient I saw today, I said, I'm not your mom, I'm not your boss, I'm your doctor, I'm your partner in your care. So I don't have ego invested in what you do. I have so much ego invested that you know your body better than anybody. You know all about what's going on. And now you have the options. You know what you can do to feel better. The name of my book is I Want to Age Like That. And it's because we all have a different that. So again, that goes back to what's your why. And then, the next thing I want to talk about is probably one of the most common questions that I get is, why am I gaining belly fat? So even women who you might look at and say, wow, you're thin, why would you ever complain about your weight? Sometimes even women who, let's say, are thin and overall, but they start to gain weight in their belly. And, I want women to know why, and then make a decision based on what their options are to see if that's what they want to keep going. So I thought I'd tell a story about Maria, again, not her real name. And she's a patient who came to see me because, she was 43 and she was starting to gain a lot of weight. And she came in and she said, I gained 25 pounds and I have no idea why. And I'll tell you, 20 years ago, if someone would have asked me that, I would have said, internally rolled my eyes. Like, what do you mean you don't know how to gain 25 pounds? Wouldn't that be really obvious why you did that?
Yeah.
But what I've really learned, it's so much more than calories in, calories out. It really is.
Absolutely. I might want you to say that again, Dr. Diana. A lot of people need to hear that.
It's way more than calories in and calories out. And so what happened with Maria is the first 5 pounds made all the sense in the world. anybody could have figured out, including her, why she gained that 5 pounds. Her mom had been sick. She had little kids, and she wasn't able to exercise. And Maria, was of Hispanic descent. They ate a diet that was very culturally white flour tortillas, white rice. And so because of the type of diet she ate, and because of not exercising for a couple weeks, she gained 5 pounds. Okay, that makes sense. But the next 15 to 20 pounds just came on. Now she could exercise more, but she still had all this stress. And as I asked her questions, I said, did you have diabetes when you were pregnant? She's like, well, yeah. Did your mom have diabetes? Well, yeah. Did your grandpa have diabetes? Yeah. Do you have any extra hair growth on your chin? Do you have chin hair? Well, yeah. Could you tell? Did I miss anything? Do you have any more acne? Yes. So what tends to happen is some women, especially even at a younger age, are what we say is insulin resistant. And what that means is that their bodies are very sensitive to even a little bit of weight gain in the belly. And that weight gain makes their body crave sugar. And so when they eat a little bit of sugar, it makes their blood sugar go higher than it should. They get a bigger insulin response from their pancreas, and it pushes that sugar straight to fat. There's no choice. And so
because our bodies want to be intuitive, right? Our bodies want to help us out and make sure, hey, I'll take care of that for you.
Exactly. And it's even more than that in the sense of being insulin resistant. What that means, especially for Maria, she had a whole family that was diabetic. And so the insulin resistance is in her genetics. And it just, again, means that if Maria eats a muffin and I eat the same muffin, and luckily I'm not insulin resistant, so we eat the same muffin, her blood sugar is going to go higher than mine. And because her blood sugar goes higher, she gets a bigger insulin response, which pushes it straight into belly fat. And so basically, it's not that Maria was craving sugar, it was that her belly fat was craving sugar. And as it gets fed, it gets bigger and louder. And so that sugar couldn't go to her muscles, it couldn't go to her brain and help her think, it would go straight to her belly fat. And in belly fat, we store our prohormones, and they get converted to estrone and testosterone. You don't have to remember the details other than those prohormones that get stored in belly fat, they are what make chin hair grow. And so, it's one of those signs that is also increasing your risk for heart disease. And so once Maria had a sense of why, then she wanted to know what to do about it. And everything we do at True is we go back to, we can talk about Candida. Sorry, I saw that. Yeah. So once we go back to, thanks, Michelle. What do we do about that? So number one is we go back to seeds. So, so many women would come to me and say, what's the magic wand? What's the magic pill? And I'd say, well, there are pills. I don't have a wand, but there are medicines that could help with this. But everything's got to start with a healthy foundation. We call that the seeds. So if you come to True, or even if you give us an email or a call, we'll send you a symptom circle. So on the back of the symptom circle are the seeds, or you could go to the website and download the Seeds ebook. It's free. You just have to go to the website and download the book. But the seeds are basically the 7 essential elements of daily success. And so it starts, number one, with sleep. And so, for example, if you're sleep deprived, you're going to be more insulin resistant. When we're sleep deprived, our bodies are in stress mode. And when we're in stress mode, one of the things that goes up is insulin, and insulin makes us crave sugar. So there is this great study done with 25-year-old men, high testosterone, lots of muscle mass, lose weight easy. I'm going to make them sleep deprived for 4 days. On the end of that 4th day, their blood tests show me that they're insulin resistant. Their bodies are craving sugar. Their insulin levels are high. And then if I put in a room full of bacon and eggs or donuts, what are they going to go for? They're going to go for the donuts. So if you are sleep deprived, yeah, you're going to crave a donut. And if you eat a donut, all you're going to want to eat the rest of the day is sugar. And every time you eat another bit of sugar, it goes straight to your belly fat. So back to sleep. Sleep is so important that we get 2 sleep cycles. The second one is water. Water has a lot to do with our energy and, of course, how we look with our skin, but it has a lot to do with energy and not having hot flashes. But for Maria, the main thing that I want to talk about to her is it was her diet. So at True, we talk about a healthy diet being complex carbs, protein, fat, and then treats. One treat would be, we get one treat a day. A treat is something that would be a simple carb, like white rice, white flour, white tortilla. So Maria said, I am in the habit of eating a white flour tortilla. I really like that. I'm like, fine, you can have one a day. That's your treat. No white rice, no alcohol, no sugar, no chocolate. You get one treat a day. But every 3 to 4 hours, it's super important to have complex carbs. So for breakfast, that would be like a piece of Ezekiel bread and an egg. So carbs, good versus bad. Thank you for that. So my favorite book about this is called Sugar Busters. It teaches the glycemic index of foods. So the key is that we've got to keep our blood sugars nice and stable. Now this white rice would be the one treat, and the rest of the veggies around are great. But what I would want to add to that plate would be a complex carb. So it would be a piece of brown bread. It would be a sweet potato. And I would rather choose to not have the white rice, and maybe I'm going to have, something later. But let's say I want white rice sushi. That's my treat for the day, is that white rice. If you want a glass of wine, that's your treat for the day. But again, it's so important to do a complex carb every 3 hours. So it's not a lot of calories. So recently I had a patient who, again, you would look at and say, wow, she's really thin. But she's 47. She's starting to gain a little bit of belly fat. And we checked her blood sugar, which we check labs on everyone before they come to the office. So we already have a sense of that. And she was pre-diabetic. And here she is, just thin, like you never would have thought. So in a regular system, they never would have drawn a blood sugar on her that we drew. So all she did, she said, well, can you give me a medicine? I said, yeah, maybe, but let's just try diet changes. Let's just give it 3 months. So all she did different was she added a piece of Ezekiel bread at breakfast. She added Triscuits at her snack at 10 o'clock. She added brown rice to her lunch. Her snack in the afternoon was an apple and, let's say, some nuts. And then dinner, no carbs. That's the other big trick. After 4 o'clock, no carbs. If you're insulin resistant and if you're not going to do a lot of hiking after dinner, no carbs after 4. So she adopted that for 3 months. That doesn't mean you can't have a beer on Friday night, cut loose, but, in moderation and maybe one night a week. That's all she did for 3 months. Her blood sugar is back down and her belly fat is gone and she has energy. She has energy. And so keto does not work for women who are insulin resistant. Keto does not work the week before you have a period, when your estrogen is low and you're more insulin resistant. Keto does not work for menopause. It's so important that we have good carbs.
So we had one question come up with how do you address disordered eating?
Here, I can read this.
Yeah, her question is, I'm always concerned about treats and options related to the option for limiting options because of the risk of binging. So
I hear you.
Yeah.
Yep. And so, for example, sometimes, again, that's such almost an individualized question because it's really understanding where that comes from. And I don't promise to be a licensed therapist, but knowing women so well, it's like, where's the fracture wound? Where's the source of that desire to control? Where is the background, the history that leads to that desire, maybe for control, or what triggers that to be something that could trigger a question about binge eating? And so, at True, we have an amazing therapist, Ashley. We have a nutrition coach, Anna, and myself to help get to the hormonal, the physical parts of that. And we work as a team to help you figure that out. For some people, having a real set rule is helpful. For some people, to your point, the last thing you want is a rule, and maybe can we help in a different way? It all goes back to what do you want and how bad do you want it and why do you want it? And so maybe there's some other solution to that. Maybe that's if somebody's insulin resistant, maybe the diet's not so bad and we add the metformin. So again, I would really welcome that question in a one-on-one so we could help kind of get to the bottom, the root cause of where the disordered eating came from in the first place. So I hope that's helpful, but very valid and very common. Any more questions about belly fat or that whole concept? It's so important. I guess I want to say one more thing on that. If there's no more questions, is that why is that so important? It's because belly fat and high blood sugars, does keto work if you're not insulin dependent? I'll come right back to that. So belly fat, high blood sugars are one of the biggest risk factors for heart disease, dementia, diabetes, obesity as we get older. And so it's one of those things that's so critical to have a handle on. Not only does it really impact our health, not only is it preventable, and there really are ways to figure this out, even when there's more, minutia or more personalized details to figure out, but it really does affect how we feel every day. How many people are stressed because they can't get their jeans on? How many people are, get more hot flashes and night sweats because they gain 10 pounds and it's like wearing a sweater we can't take off. So our weight really, can impact not only how we feel, but our health. So there was a question, does keto work if you're not insulin resistant? It can, and it has to do with that, the whole concept of intermittent fasting or keto low carb. I think that if someone wants to jumpstart and really change their metabolic patterns, maybe you've been in a habit of eating a lot of simple carbs, let's say a lot of white bread, white rice, white tortillas. And so you've been in the habit and just switching over, your metabolic patterns, it doesn't hurt to do keto for a bit. But again, do you need energy to think and work? I just don't think it's a good long-term plan. Now, there definitely is data around intermittent fasting, not necessarily the feeding window where people don't eat till noon and then they eat for 4 hours and then they eat again, but much more in the sense of, let's say, a 24-hour cleanse. And there's all different programs out there. I really like the Isogenics program and the cleanse program. So there's all different tools, and at True, we talk about that program, but it's all about having that cleanse maybe for 24 hours once a week, once every 2 weeks to sort of reset and make sure you're getting a lot of electrolytes and vitamins and adaptogens during that week of during that day of cleanse, and then go back to a really healthy, complex carb, protein, healthy fat eating plan. Does that make sense? Okay, so here's another thing that as we women know our bodies, it's so critical that we know our phase of ovarian function. Because number one, when you know your phase of ovarian function, your body isn't so confusing. I don't want you to be confused by your own body. Number two is that it really can explain a lot of symptoms, and everyone is so different. So just let's go through the basics here. I won't quiz you on this afterwards, but I want you to know the basics. Number one, reproductive phase, of course, is that time where you're most likely to be able to get pregnant. And mid-reproductive phase is when everything just feels normal. You have a period every month. If you weren't on a birth control or an IUD. So it's one of those things that reproductive phase is when your period is regular between 26 and 34 days. It's just, it makes sense. And nothing is too crazy, maybe an occasional menstrual migraine, maybe a little PMS, but nothing to write home about. Nothing that anyone is saying to you, hey dude, you're getting a little cranky. So nothing crazy. Late reproductive phase is when your hormones start to change a bit more, and it has to do with how many baby eggs you have left in your ovary. So these phases, we can tell where people are because of the pattern of their periods. And I want to, if it's okay, pull back a little bit more, because I think women so need to know this, and we don't always think about it in these basic terms. I want you to think about your uterus like a balloon, and it sits in your pelvis, and your cervix is a little thingy that hangs down from the balloon. So your uterus is hanging out there. And the inside of your uterus, I want you to think about like your lawn, like the grass outside. the hormones that come from your ovaries, they come from cells around each one of your baby eggs. And when you run out of these baby eggs, you run out of your girl hormones, estrogen and progesterone and testosterone. We girls make as much testosterone as a guy, we just express it differently. And so our ovaries are what making our hormones, estrogen, progesterone, testosterone. And as we run out of baby eggs, we run out of hormones. And the fewer eggs we have left, every month we go through a couple of those eggs. We call them follicles. And so our brain and our ovary are always talking. So our brain tells our ovary to make an egg. The ovary starts to develop an egg. The little cells around it make our estrogen, our progesterone. The cells in between make our testosterone. And I want you to think about estrogen as fertilizer and progesterone is weed killer. So estrogen is fertilizer, progesterone is weed killer. So what happens is that these hormones come out of your ovary and they make the lining of your uterus grow. And so as the lining of the uterus grows, if you're pregnant, the hormones keep going and the lining stays stable. If you're not pregnant, those little cells die, hormone levels fall, and the lawn gets mowed. You have a period. In the reproductive phase, again, those cycles are nice and regular. And if your cycles are regular, that tells me everything's good. Your sugar levels are good, your insulin levels are good, your thyroid levels are good, prolactin's good, like it's all good. It's like a vital sign. Again, in late reproductive phase, it means that your ovaries aren't starting to work as well. And so what happens is that you might have a hot flash or a night sweat the 3 nights before your period. You might get a bad menstrual migraine. You might get pretty significant mood disturbance, not just a little PMS, but you might get depressed or anxious to the point where it changes how you feel on the inside, and it starts to maybe even change how you are acting on the outside. So that late reproductive phase, your periods are still regular, but you start to have some symptoms. So it's kind of like something's going on. And it makes me mad when you might go to your doctor or your nurse practitioner and they say, oh, honey, you're too young for that. You're too young for menopause, but you're certainly starting to experience some changes as related to your menstrual cycle. Perimenopause means when your periods start to change. They start to get early or late. And the typical thing that happens is that periods get a little closer together and they get heavier. And it's because you're still making fertilizer, estrogen, but you're not making as much progesterone or weed killer. So that lawn gets a little thicker and it falls off a little quicker. And so as that progesterone level goes down right before a period, your periods might get to be, let's say, even every 20 days. So you're like, oh my God, I'm always having my period. And then it starts to get a little heavier. And then it tends to spread out. You might drop a period. You might spend a lot of money in pregnancy tests. And it's just that you're in perimenopause. Late perimenopause is where you might go 60 days without a period. And then boom, you get now 3 periods in a row. And then you don't have a period again. Late perimenopause is when you start to have more symptoms. Hot flashes, night sweats, mood stuff. We can talk about all that. But you start to really feel like, okay, what is going on? I do not feel like myself. Menopause means no period for 12 months. Now, spontaneous menopause means your ovaries, they're in retirement. They're done. You ran out of baby eggs. For most people, that happens around 52, but there are patients with premature menopause that can be a genetic thing. It can be related to, mainly it would be a genetic thing, but it can happen sometimes early. But again, it means 12 months of no period. Now, some women might have early menopause. My patient with the earliest menopause I've taken care of, she was 15, and she had cancer, had radiation, and the radiation killed her ovaries, and she went into menopause at 15. I have patients who go into menopause at 32 because of breast cancer and because of related chemotherapy, or they have surgery for, let's say, endometriosis, and they have both ovaries removed. So some women have menopause at earlier phases because of other reasons, but it means no period for more than 12 months or your ovaries have been removed. So is this information helpful? Okay, good. So it's, again, so important that you know where you are so you can have a sense of what's going on with your body. So next slide, maybe. Okay, good. So hot flashes and night sweats. So this can, hot flashes and night sweats can happen before you're 50. So I know we've got people of all ages and all phases on here, but just to talk about this, at least for a minute. So in your brain, you have a thermostat. And again, if you're listening and you're 25, now at least you can help the older women in your life know what's going on, or you can be a little bit more sensitive perhaps. But what I want you to think about is that in your brainstem, you have a thermostat. Your brainstem is what controls your blood pressure, your heart rate, and it also controls your body temperature. Us girls, we're not lizards. We can control our body temperature within reason. And so our thermostat is constantly monitoring our blood, our body temperature, and it's got a comfort zone of about 4 degrees. So just like the thermostat on your wall, it controls the temperature. So I want you to think about the thermostat on your wall. If you open the window and the cold air from tonight comes in, it will sense the cold air. And what does it do? It turns on the heat. That's a shiver. That's what we do when we're cold. Our body says, you're cold. We want you to shiver and heat the body up. If we get too hot, what do? We sweat. That's our air conditioning coming on. And what happens right before a period or in the perimenopause or in the menopause, what happens is that with a loss of estrogen, our thermostat, the comfort zone gets really narrow. And this was really very elegantly discovered at Wayne State with a researcher who had a room. He could control the temperature within seconds and within many degrees. And he was really able to understand that it's all related to our internal thermostat. So before menopause, we have a 4-degree swing where we can get a little too hot, a little too cold, nothing happens. In menopause, often women will say, I'm always too cold or I'm always too hot, because their comfort zone is 0.4 degrees. So if they get a little bit hot, so the classic story is a woman who's like, I was freezing before I went to bed. I put on my flannel jammies, got under my covers, put on an extra blanket, and I was out. And then they wake up 20 minutes later in a sweat. Because what happens is that they go to sleep, they're under the covers, maybe they've got a bed partner, maybe they have a dog that climbed on top, and now their body temperature went up. They used to be able to tolerate it. Now the thermostat at 0.2 degrees above normal, the air conditioning goes off, and that's the sweating. That's trying to get rid of heat. And then of course, so many women say, then I sweat, and then I overcool, and now I'm freezing. So now covers on, covers off the entire night. So low estrogen changes our thermostat, and so do brain chemicals, especially serotonin. So women who have had chronic anxiety, depression, they have low serotonin maybe in their brain, their thermostat also can get a little wackadoodle earlier than they would expect to. So that thermostat is really sensitive. And for women, for example, who have breast cancer, can't take estrogen in their blood, we can give them medicine that elevates their brain chemicals, and that chills out their thermostat. So there's a lot of good science that we know about all this. Also,
we have a couple of questions, Dr. Diana, and one of them is, can you have random fever spikes during those, when your thermostat is trying to adjust that? Sarah Badger is commenting, can you have random fever spikes that last for a few hours with the sweats?
So again, it's temperature instability. So what feels like, it will feel like you're hot, because what happens is your body is trying to get rid of the heat. So like when a dog pants, it's like getting blood and opening the mouth to the tongue so air can pass. The same thing is happening with our skin, is that our blood vessels dilate, all the blood goes to the surface so it can exchange the heat with the outside. And so if you're overheating and your blood vessels dilate, but yet you're, let's say, in a warm room, or you're at work and you can't leave your desk, or you're working or whatever, so you can't really get rid of the heat. So the body is going to stay dilated. It might feel like a fever. And if we take a temperature check of a woman's skin when she's having a hot flash, it's hot, because all of her blood vessels are dilating and her skin is hot, trying to get rid of that heat. So the other thing that people will ask about a fever spike, is some people actually have immune system changes with hormone changes. So I've had women have rashes around the time of their period, or they always get sick. They always get a cold or something around the time of their period. So it'd be interesting to see what it is, but it could certainly feel like a fever spike around that time.
I think she's implying that she's actually taken her temperature and has had a spike during that time.
So, I'd want to look at other stuff, some autoimmune stuff, but certainly it can change your temperature stability. So
We have another question as well. What about ladies who have had a baby and then are always hot after having a baby, never before? Asking for a friend. Oops, I think you're muted. Dr. Diana, you want to repeat yourself? Oops.
Okay, I was muted.
We're there now.
Okay, good. So in terms of hot after a baby, for some women, it could be, let's say, the weight gain that happens because of a pregnancy, and until that weight comes off, they might be hot. I'm getting feedback.
They might be hot.
Yeah. So we need everyone to
So
mute.
we need everyone to mute their.
I think I got it. We're good to go.
Okay, so number one, for some women who are hot after having a baby, sometimes it's because of that extra weight that was gained. And until some of that weight comes off, it's like wearing a sweater we can't take off. But more commonly, after you have a baby, especially if you breastfeed, what happens is that when that baby comes out and then that placenta comes out, your estrogen goes from here to nothing. And so that change can definitely cause hot flashes, especially a lot of women after having a baby are sleep deprived. So sleep deprivation and low estrogen can certainly trigger, having hot flashes. On top of it,
so a soup for hot flash.
Exactly.
Yeah.
And on top of it, especially if you're stressed out, if your estrogen is low, you're not going to make as much brain chemical as you did before you had that baby. And so not only is that a setup for hot flashes, it's a setup for postpartum depression. And I see there was a question about PMS. One of the components of PMS, other than bloating and bowel changes and all that, but one of the components of PMS can be mood change. And so, we'll talk about that too in a minute, but when your estrogen goes down, you go through your brain chemicals quicker. And when our brain chemicals are lower, especially serotonin, we're at more risk for, let's say, a hot flash or a night sweat, but also we're more at risk for mood disturbance. We're more at risk for being more irritable, being more depressed, not feeling like doing the things that we like to do. And so, there are a lot of self-care things that we can do for ourselves, but it's knowing that why, and there really is a physiologic, a body reason for those responses. So it's real.
I want to make sure we get to, oh, good, this is our next. I was going to say, I feel like there's so much information, but one of the key things that we discussed is that you felt as a provider that you were not educated in the area of talking to clients about sex. And
Correct.
So you created, and show us, if you will, you created the sex deck. So there's 27 or 28 questions that are all in the sex deck. So I thought we could just go through a couple of them. I don't know Perfect. If you'd be willing to take one out and just show us what happens if I came to you and said, yes. Here, Dr. Diana, this is my card. This is my issue. Let's walk through it.
Perfect. So just real briefly, we know that 80% of women have sexual health concerns over their lifetime, and about 40% of people will truly have low desire. But before we get into the cards, just real briefly, I want to talk about spontaneous versus responsive desire. So one of the many things I've learned about sexual health is that it's not so simple. It really is different for everybody. And it's one of those things that can be hard to talk about for us providers because we're not trained. We don't know how to talk about this. And so many women don't want to talk about it because they feel alone. They feel ashamed. They feel like I should just want to have sex all the time, or my partner wants to have sex and I don't want to have sex.
And we live in West Michigan.
And we live in West Michigan, and it's not been something that we talk about. I mean, there's so many words. I don't know how much we want to say on this call, but there's so many words I couldn't even say as a doctor. Like it was just, and so it's really important that, I was able to go to conferences and learn and get a lot more comfortable with this language. And so, it'll help. And so just very briefly, spontaneous desire is where you have that desire, you just spontaneously think about sex, whatever that means to you. Whoever you're attracted to, however you think about that you might just think about sex. Responsive desire is where a certain cue might cue you to think about sex or want to engage in sexual behavior. And responsive cues or cues that you might respond to would be your partner saying, hey, and you're like, hey. It might be a movie, it might be a song, it might be a certain day of the week, you know. So, you know, with responsive desire, you weren't really thinking about sex, but that cue, once it happens, you're like, oh, okay, I'm good with that. Let's engage.
And so what you're saying, Dr. Diana, is that we should have both, correct?
Well, there's no should, right? Like,
okay.
It's nice if both are there. Let's just say that.
How to say it correctly.
Yes, but some women might have spontaneous desire where they just think about sex, but they don't respond. Maybe it's because they don't respond to their partner and there's partner issues. Maybe they have pain and they don't want to engage, let's say, in penetrative sex. Oh, we lost our deck there. That's all right. Okay, there we go. So maybe it's we don't respond to that cue. I had a patient who had recent surgery for breast cancer, and she had a lot of issues with self-image, and she just didn't feel sexual. And so she still loved her partner. She could still think about sex, but she had no desire to respond to any sexual cues because she felt like she was less than, and she felt like she was disfigured by her scars. And we really had to do a lot of body positivity work and to really work on some safe words for her, and to really, you know, she decided that if I wear a t-shirt during sex, then it covers up what bothers me and it makes it less likely that I think about that. And if I ask him not to touch the areas where I had surgery, then it helps me not mentally go there, and I can focus on all the other positive things about her.
So then her body is able to respond to that. Yeah, okay.
Exactly. So the cards are color coded. And so, for example, what would happen if you came into the office and you said to the nurse, said to Amy, I have low sexual desire. And she would say, okay, let me go get the sex deck. And so she would say to you, why don't you go through the cards and pick the ones that you think might apply to you, just even in general, just it really clicks with you. And so, for example, then once I walk in the room, if I see all blue cards, I know that it's probably a relationship type thing. If it's all red cards, I know that it's going to be more of a psychological thing, and we'll pick a card from each category. And if it's orange cards, it's more likely to be a physical thing. So let's go to a real common one in the physical one. Let's say, oh my God, they're all so common. Let's go to painful sex. So yeah. Painful sex is a pretty, unfortunately, common cause of low responsive desire.
Especially as we get older, right? Like there's an element of that.
It can be. And so, for example, I had a patient who was 26 and all of a sudden starting having terrible pain with sex. And it got to the point even where she would have an orgasm and she had crazy pelvic spasms and pain. Like it made her just not even want to go there. Oh. And so I saw her. So on the back of the card are the reasons for why that might happen. And then what are options to do about it? And so to read from this, the number one cause was what made me think of this former patient is pelvic muscle spasm. So this patient had been a gymnast. She did the gym aerobatics where you're on the ribbons and you float around in the sky. She was also intense Pilates. So she did a ton of exercise with really incredible core strength. Her hips were tight. She could do Pilates all day long. That woman could do a Kegel like nobody else. Like all her parts were way up by her ears. Like nothing was ever going to fall out. But part of that is that her hips were tight. She did all this core work and all this strength work, but she never stretched. And so, you know, especially after a hard workout, her pelvic floor is so tight that anything going in the vagina, she was heterosexual, she had penetrative sex. And what happened is that caused a pelvic spasm. So she said it felt like there was a wall in there. It felt like he was hitting a wall. Well, it was a wall of her pelvic floor. And because of that one time having that pain, she would go into pelvic spasm, even if it was a thought. And so for her, we used actually vaginal Valium. So she would put a Valium pill in her vagina. It didn't help relax. That wasn't the goal. It helps the muscles relax. She did a lot of pelvic floor physical therapy, hip openers, pigeon pose, all those hip opener yoga poses. She really backed off from some of her strength training. And then she also used a vaginal dilator. There's a vaginal dilator called Millie, and Millie is a vaginal dilator that goes in the vagina, and you hit a button on the handle and she expands. And what that does is it helps the muscles of the pelvis stretch and not be so scared anymore. It's not a sex toy. It truly is a dilator to help those muscles. And so with everything together, she was able to learn at 26, hopefully how never to have pain with sex again. For some women, they have dryness from low estrogen. Another cause would be lichen sclerosis, which is a skin condition of the outside that can even happen to a young woman who's on a low dose birth control pill. It can happen to a woman in menopause. So lichen sclerosis, unfortunately, is not that uncommon. And it's something that we can treat, diagnose and treat if you see someone who knows what they're doing around that. A woman who has endometriosis, that can cause painful sex, especially deep penetrative sex. And uterine fibroids can cause a pressure effect where sex can be painful. Pelvic radiation treatment. I see a lot of women who have anal cancer, for example, and that tends to happen related to HPV infection, especially for women who weren't young enough to get the vaccine when that came out for HPV. And so HPV can cause anal cancer. The treatment is pelvic radiation, and that can cause a lot of painful sex. And so I see a lot of patients who have had anal cancer, and we're able to help them not only with menopause, because it also can affect their ovaries, but also help get over the hurdle of painful sex. And then just having pain in the past can cause that. And so I've talked about some of those treatments. There's lubricants, there's moisturizers. And for women with low estrogen, let's say even after having a baby, we can even use vaginal estrogen that doesn't go into the system. And at True, we also do a procedure called Mona Lisa laser, and it's a laser for the tissues of the vagina and the outside of the vulva that help treat low estrogen related symptoms. So again, there's a lot that can be done. So that's a physical. Do you want me to also talk about a psychological one?
Yeah, let's hit a psychological one before we go on to your next slide. Okay,
cool. So I'm just going to talk about the poor self-image for a minute. So poor self-image is unfortunately pretty common issue where, it's the two most common reasons for low sex drive after, let's say, the age of 40, 45 is poor self-image and lack of emotional connection, which is one of the blue cards, insufficient intimacy. So, if you say to me, hey, I love my partner, it's okay, and we've had good sex in the past. I say, well, you love them, but do you like them? Well, not really. So I would say, well, why do you want to get naked with somebody you don't even like, or you don't respect, or you don't feel close to, or you don't feel has done anything for you that really makes you feel special? And then on top of it, if you have poor self-image because you've gained weight and you just don't feel like yourself, you've had surgery and you've had a scar, so we talk a lot about those things that maybe that can be really powerful to help you feel like being motivated to exercise, for example. But it's all about how you feel. And, the relationship stuff can be a really powerful time to use this to come together. I had a patient who, I asked her, I said, what is the last thing that your husband did for you that made you feel special? And she said, I can't think of anything. I'm just, we're not in a real great place right now. I said, come on, there's got to be something. And she said, oh my God, he hung the closet doors without me asking. I'm like, okay, there we go. So if you want to have sex with him, you want to maintain this intimate relationship, it doesn't hurt, you feel okay about yourself, you feel safe, you want to do this, one of the things to do is to think about those closet doors, and you get all twinkly and you remember why you like them, and then you can be intimate and be okay. So there's lots of, those little tips that come out of this sex deck that we can use to really help people feel like themselves again.
Can we even if we're not your patients, can we purchase the sex deck to even have for ourselves in our home?
Yeah, you just go on the website and it's there. And so they're just really helpful to have. My goal is that this is in everybody's pocket, from provider to person out there, because again, it's just, women shouldn't suffer in silence. It just makes me crazy that people feel bad just for lack of knowing why, number one, and number two, what to do about it.
Great. All right.
Mood.
Mm.
This is a big one. So I want, again, I love the name of your organization, Women Who. I want women who, are knowledgeable about their bodies to be able to acknowledge barriers. So many women with mood disturbance, irritability, depression. I love the word anhedonia, being in that state of not wanting to do things that we normally like to do. We have to acknowledge barriers. And one of those barriers is mood changes from Sharon. The website is truewomenshealth.com, and the last slide has those links. So we definitely will share those. And Michelle, maybe you can put those in the chat. But anyways, I want you to acknowledge mood changes really have basis in body chemistry and what's going on even with your hormones. So I had a patient recently, and this is a common story. I just don't feel like myself. My life is pretty good. COVID, even COVID has had some blessings. We're home more. I feel like I know my kids better. I've reconnected with my partner. Like, life is pretty good, but I just feel anxious all the time. Like what is going on? And so it can be really, really disturbing, or someone says, I was at Costco and I had a panic attack. What was that? Like, it just made me feel out of control. And so having this sense of anxiety, even though there's not a cause, the first thing we do is talk about what else is going on. So for example, for someone, it might be that their periods are getting all irregular. And right before a period, especially in the perimenopause, the estrogen drops really quick. And when our estrogen drops, we go through brain chemical quicker. Family history is really important. If your mom had depression, if she had anxiety, if your sister does, if you had postpartum depression, for example, if you had depression in the past, all that means is that your brain system is more susceptible. And I like to think about brain chemicals, if you'll allow me an analogy. Brain chemicals are like money in the bank. And even if you have paper and pencil in front of you, I want you to draw a little chart and write on the top serotonin and put a little dollar sign by it. I want you to think about serotonin is like money in the bank. So just like you would think about a balance sheet for your home accounting, you know how you make money and you spend money. And if you run out of money, you don't get to buy stuff. So you make brain chemicals. So on the plus side, I want you to write underneath it, write sleep. So you make brain chemicals when you sleep. And we need 7 hours. 7 hours is where we get 2 good sleep cycles. And it's true, we talk a lot about sleep hygiene and meditation and metered breathing and gratitude. We talk about all the tools that help us really get that 2 hours of sleep. So if we sleep for 7 hours, we make brain chemicals. Also on the plus side, I want you to write genetics. Some people make more brain chemical than others. And if you think of a family that you know of, hopefully it's not yours, if everybody in the family is cray-cray, then part of it maybe is that nobody makes enough brain chemicals and maybe makes poor decisions, which then leads to more stress, which then leads to more cray-cray. So maybe the original cause is that you just don't make enough brain chemical, and that's okay. Some people don't make enough insulin. We give them insulin. Some people don't make enough brain chemical. So I'd like to think, we all, again, let's just, too much to tell you all at once, sorry. So again, we make brain chemical when we sleep, and we make brain chemical genetically. Some people make more than others. And medications that we use for depression and anxiety have brain chemical in them. So we put that on the plus side. So say medications. On the spend side, the negative side, we spend brain chemical for life events. And so we spend brain chemical, for example, if our clothes don't fit, we spend a little bit of brain chemical. We spend a lot of brain chemical if our parents are sick. Heaven forbid we've lost someone to COVID. If we lost our job because of COVID. If money is tight.
If we're in a global pandemic.
Just a little issue.
Yeah.
So again, the bigger the worries, the more brain chemical we spend. And we spend even more brain chemical when these events are unresolved. Let's say you lost your job and you don't know when you're going to get one again. Your child is struggling with drug addiction. I mean, and you want to help, but you don't know how. So the more that there are unresolved things on your plate, you're constantly spending brain chemical to try to figure stuff out. Also on the spend side, I want you to write low estrogen or low E. When your estrogen level is low, you go through brain chemical quicker. And so what that means is that you might make enough brain chemical, you might be sleeping okay, but when your estrogen goes down, you're going to go through it quicker. And so again, think about this like a balance sheet. And if you have a deficit of brain chemical, that's one of the causes of depression, anxiety. I mean, if you think about it, everything goes back to that. And so if you have a deficit in brain chemical, it's to go back to the chart and think, what can I do about this? Can I just really work on my sleep? Genetically, I can't do anything about that, but maybe it is time to consider a low dose medication. Medications can be used even for a short period of time. You know, there was a time, I don't know, 10 years ago, I took Lexapro for 2 months. I've never needed it since. But my life was just, I was working 120 hours a week. I had 3 little kids. My nanny, who was my aunt, was in California for the summer. My husband was traveling. I was working an hour away from my house. I had 3 little kids with a sitter that I didn't really trust. So I had nothing left. I didn't just stare, yell at my kids. I was staring at the wall. And thankfully, my dad, who's a doc, said, you got to do something. So I went on Lexapro for 2 months, got a new sitter, stopped working 5 days a week. I went down to 4 days a week for the summer, hired a new sitter, made some decisions, spent more time with my kids. Oh my gosh, I went off the Lexapro, never needed it since. It was a tool to use for the time. And so then I was able to problem solve, go to bed on time, make better decisions. And so it's one of those things that, again, just think about it like a tool. If you have unresolved life events, where can you apply the serenity prayer? It's the wisdom to know what can you change, what can't you change, and the wisdom to know the difference. And so what are those things that you can make a difference about? What are those things that you can't? And then we have gratitude, and we have meditation, and we do yoga, and we exercise. All those things we cope, but to really work on getting rid of those unresolved life events. And then estrogen for some women, we don't give estrogen to fix moods necessarily, but we know that, for example, women in the late perimenopause, or I'm in menopause, I take estrogen. So I know that really does affect my mood. I get a little less myself if I don't take that estrogen. And so for me, it's a really important part of me feeling like myself. And so for women who it's safe to take, taking estrogen can definitely help the moods. And for some women, let's say in their 30s, they'll even go in a low dose birth control pill to really even out their hormones so they don't get those fluctuations and get that PMS. So bottom line, it's taking everything back to that balance sheet and figuring out how this applies to you. So again, women who know, you got to know that there's good science around what's going on with mood disturbance. Periods. So again, we went back to the analogy of the uterus like your lawn. And the uterus can be your friend when you want to get pregnant. It can be a part of sexual function. It's nice to know all the parts are in there and doing good work for us. But for some women, their uterus might develop, for example, fibroids. It might develop these benign growths that make growth, GROWTHS, growth. It can cause pain, pressure, and very heavy bleeding. Some women can develop endometriosis. But how I want us to think about this is that, there are definitely options that don't even necessarily involve surgery. So I remember having a patient with fibroids and heavy bleeding, and it started to affect her career to where she had to leave meetings because of bleeding. She had to stay home because of bleedings. Of course, now we all are staying home, right? There's a lot of us. But it was really affecting her career. She was missing meetings. And so other people were standing in for her, and she started to lose touch with, and she felt like she probably missed a promotion or two because of this. And for her, the right thing became surgery. So I did her hysterectomy, and she did fine, and she was able to catch back up. We use the IUD a lot, and especially in perimenopause, the IUD can be a really safe option for control of bleeding and also for family planning. So it can be something that's really helpful to use. Again, bottom line, I want you to know your options. And so if you have issues with heavy periods, frequent periods, number one is to make sure there's nothing going on that's not safe for your health. For example, women who don't have periods often, who have PCO, if you have that, you'll know what I'm talking about. If your periods are spaced out, if they're heavy, even women who are, let's say, younger can develop even pre-cancer or uterine cancer if their periods are spaced and heavy. So it's something, first of all, it might involve a biopsy, it might involve an ultrasound, but then it's to know the options. And the options might be just observation, it might be a birth control pill, it might be progesterone, it might be an IUD. I'm not a big fan of ablations, but for some people that might be the right option. And then pretty low on the need is the option for the hysterectomy. So I just wanted to make sure I brought up the subject. And I love this concept. There's been a lot of work around women who cope well versus women who don't cope well. Men who cope well, men who don't cope well. And researchers have really settled on these 3 factors as being important. Number 1 is believe you deserve to be happy. Number 2, so again, do you believe you deserve to be happy? That really can empower what we do to help us with coping. Number 2, it's to keep a network around you. So Rhiannon and I had so much fun talking about your organization and how we think about this, but we've got to have community around these questions to help support each other. And so it's to keep that network and maintain it. It doesn't just happen. I remember one time sitting at dinner with some girlfriends and saying, you guys, this isn't optional. We all struggle to get here. We catch flack from our family members for leaving. We have to make this a priority. We need to support each other. So the fact that you all volunteer to make this organization what it is just incredible. At True, we're working hard to form our community. We have a private Facebook page that's gotten very active. But the next thing is to ask for help. If something doesn't make sense, ask for help and be bossy, be persistent, be that squeaky wheel to ask your friends for help. And I had a patient today who was like, I don't like to ask for help. I'm having depression issues and I'm ashamed. I don't want to talk to my family about this. I'm like, people love the opportunity to give. And how, you give and give and give. When do they get to give to you? This allows other people to also help you if you need it. So again, these are the 3 factors.
I loved that as I completed on the app, there's a whole section within your app for community sharing, right? This is what I'm doing. What are you doing for vitamin D? This is what I'm doing. So essentially right on the app in my palm, if I'm dealing with something, I can look to the community of women that are likely going through the same issues that I'm going through right there at my fingertips. So I did find that was amazing, Diana. So you had mentioned that community is important to you for these reasons, but you've also helped to create that.
Thank you, because I just think it's so important because as women, again, I don't know about you, but I'm a bossy Dutch girl. I don't want anybody telling me what to do. So I'm never going to tell someone else to do. It's like, here are the options. But then often we want to know kind of like, hey, did someone, how did someone else do with that? How did that work for somebody?
And I think there's a lot of women that are in that, 50s and 60s, that are in their 50s and 60s that, their physicians didn't talk about sex. So then educating those of us that are younger is a complicated process. I think opening the door to that, creating those opportunities to have those discussions is great.
Exactly. So I'm just looking at the questions to see if there's anything.
Not that I can see right now. They're just asking about if we could get the recording. We'll have the recording available for you on YouTube. Dawn handles that for us. And then we'll also send the follow-up after tonight in the newsletter. There'll be an option for that, the link to that. And then we're also live on our Facebook group. So if you are in Women Who, in the Facebook group, that will still be available to rewatch as well.
Cool. I do see a question from Marnie. Is there a way to measure your brain chemicals? Brain biopsy would be the only real option, and that's not something we generally do. So, in all joking aside, we're not really able to measure brain chemicals, but we're able to kind of really have a sense. And I saw on this chat, there is a licensed therapist out there. So, it's one of those things that we can come up with from our, from history, I wish we could measure brain chemicals, but we can't. Now, for some people where it really is fairly clear that brain chemicals are part of the issue that's going on. And let's say they've maybe tried one medication and their side effects. They tried another medication, their side effects, or it just doesn't work right. You know, the goal of a medication, let's say for depression or anxiety from brain chemicals, is that you feel like yourself on a good day. And when it's just really hard to find a medication, there is new testing that we can do, a blood test that can tell us how you process. It's that personalized medicine. How does your body process medication versus someone else's body? And it really helps us maybe find that right medication for you that could be effective, even hopefully for a short time, if that's what we need. So we can't measure levels, but at least we can fine tune therapy if that's indicated.
Right. So one of the things, and I think you've kind of gone through it, but I would love to hear it more specifically, is the 9 points that you have your clients walk through. Can you run through those 9 points for us? Because I feel like if everyone had an opportunity, even if they weren't your patient, if they looked at these 9 points in their life, they'd be able to see areas where they might want to grow or have stress point. You know, I would really love to hear those 9 points from you.
Thank you. And I was just looking, you know, to see in the book. So the book that I wrote is called I Want to Age Like That. I Want to Age Like That. And it's all in the book. And there's now a workbook that goes along with it. Where this book came from is, you know, I came up with this plan called Waypoints. And the 9 points that Rhiannon's talking about are how I was thinking about how to organize wellness in my brain so I could help my patients. And so the 9 points are A, and I'm a list girl. A is activity. B is obesity, or your risk for weight and muscle mass and all that stuff. So B is obesity. C is cancer. D is diabetes. E is ease of coping. F is phase of ovarian function. G is good bones. H is heart disease. And I is income security. So when we assess our wellness, I really believe that everything fits within those 9 areas. So back in 2008, I did a pilot study because I thought I don't want to offer a program and if we really don't know if it works. So we recruited women. It was the first person in West Michigan to talk about this kind of stuff. It was back in 2008. So we recruited women with a simple quiz. You know, are you going through life phases? Are you yelling at your kids more? Like 200 women came to the first meeting and I gave a bit of a lecture about menopause stuff. And I think 120 women signed up, and it was 5 visits over the course of 6 months. And we really did a deep dive into goal setting overall and goal setting in each one of these areas. And then we also did risk stratification. We call it the place and process. So you figure out your picture of self, how you want to be. And then we figure out your place in process, or your PIP, in each one of those 9 areas. And then we give you a life map, and the life map charts where do you want to be versus where are you. And so, for example, I had a patient, you know, she wanted to be 3 times 7. So a 3 is good and 1 is bad, or I should say higher risk for issues. So she wanted to be a 3 in all categories. 3 times 9 is 27. We figured out her place in process in all of these areas, and she was a 20. She's like, whoa, I want to be a 27. I'm like, okay, dude. So we can up your game and let's look at barriers and do problem solving and let's get you up here. Or you can reset your goal down to 20. And she's like, so I think she settled on a 25 and we worked hard to get her to a 25. But it just helps kind of put that out. So what the book is, it's the stories of the women who went through the pilot study, and it's the meat of the pilot study. So I had to learn how to write a book. I had to learn how to do research, but it was so important to me to put it down on paper, to explain it, and to get it out to lots of people. You know, especially when I first started out, there was only one of me doing this work in West Michigan, and there's 400,000 of you guys over the age of 45 in our 13 county area. So I thought, I've got to write this down. There's got to be a way to scale this, to get this information to more people. And Rhiannon, that's why I started the app, to get this to where we could have it be more straightforward. And then the workbook is a way that people can really follow that. And then when people come into the clinic, you get a journal. And the journal is a way that we can track your progress. It's another way to track your seeds. You know, in the app, you can track your seeds, you can track your symptoms, but also in the journal, we use that as your binder that you bring in every time you come. So you have everything in one place, and we go from there. So it's just all different tools that women can have to really figure out who they want to be. And again, how to navigate the healthcare system. You know, one of the reasons that I left the system to start True again was that I wanted to be able to spend the time. And I wanted to be able to create the system that no matter who you see on the True team, it fits what we offer. We offer true women's health. We want you to live your truth. And so again, it's to navigate the healthcare system, and whatever healthcare system you choose to use, it's to make sure you have your questions, to make sure you get them answered, to make sure that you are getting the support that you need and the options that you need. So know what's possible. And a lot of times with a regular system, with insurance-based care, the costs are a bit more hidden. You know, we're so used to sliding our debit card and the deductible is billed, and, you know, we're just sort of used to that system. So creating a system like at True, where we don't participate with insurance in the regular way, it's a different way to think about healthcare, and it's really catching on all across the country. You know, here in Grand Rapids, there's a couple of practices like this. A lot of times they're called direct patient care or DPC practices, but they're really picking up. And I have several colleagues, one in Cleveland, one in Cincinnati, one in DC, one in St. Louis. You know, we're the ones that they're starting this. And so again, there's some growing pains with this. You know, it's how do we communicate this?
It gives you as a provider more freedom, right? That first initial appointment is an hour long instead of 15 minutes.
Correct.
So you really get to know the person that you're helping to navigate through their hormonal health. So it is a different concept that like membership, direct care, but it's giving you the freedom to practice how you want to.
How I think it should be done. Yeah. So thank you.
Yeah. I think we have a couple more slides. The next one is just tools, right? Options, solutions. And so it talks about your book, but also where to connect with True Women's Health, where to find True Women's Health. We also put in the chat the website as well as the direct link to the sex deck, because it can be used even if it's just between you and your partner, but also for other providers. As Dr. Diana stated, other providers aren't trained in how to talk to their clients about sex. So if you're coming to them with a tool, I think that would be helpful, and then to start a discussion. So
exactly.
Take a picture of your screens, ladies, utilize these tools. I would love to know if anyone has any more questions for Dr. Diana before we close out here, and shoot them in the chat, and we'll see if we can get to most of them.
And just real quick, on the other slide, you don't have to go back to the slide, but there's a website called menopause.org, O-R-G. And if you have a loved one in another city, or you're trying to find a practitioner, even if you're not in menopause, someone who has become a certified menopause practitioner, you know, it's a pretty hard task. And so this answers a question from Julia. Do I help women of all ages? Oh, heck yes. And so, you know, for example, just in terms of hormonal health or women's health, menopause.org helps you find a certified menopause practitioner. And again, Julia, to answer your question, you know, menopause is something that got me into this field, but my true, you know, again, back to my why, I want all women to discover who they are. And one of my favorite growing programs at True is we have an Empower program for women 25 and under. It's a one-time, you know, hour-long appointment, because maybe, you know, younger gal doesn't need the membership program. But these young women come in, they're 18 or 17 or 20, and they're so nervous. And by the end of the appointment, they're like, when can I come back? This was so fun. You know, we talk about sex and family planning and mood stuff. And, you know, it's just really been a wonderful program. So
it sounds like we have a woman that had brought her 17-year-old for an Empower visit and had success with that. We also have another question. Delayed periods in teenagers. Could it be related to hormones?
It could be. So for example, the first thing that I would do is, for example, check thyroid. So if the thyroid's off, that can make the periods off. If the young woman is not eating enough calories, that's the most common cause of is not necessarily over exercising, it's more a calorie deficit. So there's been a lot of research around irregular periods in an adolescent. And what happens when there's so few calories being taken in is that the ovaries just check out. They're like, dude, you don't have enough energy for the ovaries to work right now. I'm going to kind of hang out to the side, spend the calories on your heart and your brain and basic body functions. So having really low calories can make the periods irregular. For some people, it just takes their system a while to kick in. Maybe their body fat is just low enough that the hormone levels are a little on the low side. And so it doesn't tend to be anything that predicts whether or not this young woman will have children someday. So it's sometimes just kind of the system sputtering as it's getting going. And sometimes we can kind of kick it into gear.
Especially those athletes, right? Those teenagers that are athletes, runners. My daughter's a swimmer. Her body will skip a period during a heavy or intense month.
Exactly.
Yeah. We have another question from Amanda. I have noticed that a lot of women are coming off of birth control because of what is being related to issues related to hormones from long-term use. Thoughts on this? So essentially, women are coming off of birth control because of long-term use issues.
So when you say birth control, I'm assuming you mean the birth control pill. And the birth control pill is, make sure, Christine, I'll answer that question. The birth control pill is synthetic estrogen and synthetic progesterone. And how the birth control pill works is that it's enough estrogen and progesterone to turn off the system. And so it makes the ovulation not happen. And those synthetic hormones, the synthetic estrogen is okay for bone, but it's not great. A lot of women can have such low estrogen from those low dose birth control pills that they actually have vaginal dryness. They actually have mood disturbance. They might have low sex drive. The birth control pills don't tend to hurt the cardiovascular system. They don't tend to increase the risk of heart disease. If someone's had a history of a blood clot before, that synthetic estrogen can make your blood sticky and increase the risk of a blood clot. So there are certain considerations. A lot of times too, with the birth control, let's say the birth control pill, it can reduce the sex drive. And then when women come off the pill, now they've got their responsive desire back. What happens with the birth control pills is it suppresses your free testosterone, and that can affect your sex drive. But that's why it works to help with acne and hair growth. So there's pros and cons of all of that. So it's important to see a provider who knows what they're doing about all this. And about, Julia, about IUDs, IUDs are magical, not to be TMI, but I've got one. It's just, they're awesome because it just puts the progesterone in your uterus. The progesterone doesn't go into your system. So with the IUD, it's just, there's no systemic side effects. People will say, oh, I think I gained weight on the IUD. I'm like, no. And then usually we figure out the cause for that. In terms of mood disturbance, sex drive, nothing. I mean, that progesterone just goes in the uterus. It stops the periods for a lot of women, and it provides family planning. So the IUD is great. Real quick, I want to make sure I answer Christine's question. Christine, in Australia, there is an International Menopause Society called the IMS, the International Menopause Society. And actually the past president of IMS is from Australia. I've actually did a webinar with women in Australia 2 weeks ago, and I've had a lot of questions about providers in Sydney. Actually had a woman from Perth who was on the call who asked me questions about menopause providers in Australia. And so I'm in conversation actually with the International Menopause Society to find specific providers. Now, the North American Menopause Society lists providers in North America who are certified providers, but the IMS doesn't list providers on their website. And so what I plan to do is have a link on our website, our True Women's Health website, with Community Connect, with a list or a contact with those providers. So again, I'm working right now with the IMS to come up with a list that I can spread to people that I know and have asked me that question. So I apologize, I don't have that answer right now, but they're out there. And maybe even if you go to the International Menopause website, you know, they're there, but I hope to have that information soon for you.
She said, thank you.
You're welcome.
All right. Anything you would like to add, Dr. Bitner? You've done so much already.
Talked a lot.
I do want to add, you have two you might have more than the 2 I listened to, but you have 2 podcasts that you are the guest on. And one of them I thought was genius. You talked with 2 gentlemen. Can you remind me of that one with the gentleman?
Yeah. So if any of you guys know who Nigel Barker is, he's the head judge on America's Top Model. And he, during COVID, started this podcast called Shaken and Stirred. And so the gist of the podcast is that one makes a drink and talks about whatever it is that they do. And so I follow their podcast on Instagram. He's got great people on. I was probably the least celebrity person he has on, all these famous people, but he had me on because he wanted to talk to the sex doctor. And so, of course, what he didn't know is that most of my martini was water because I was on a national podcast and didn't want to say anything stupid. But it was actually a really interesting conversation because he and his sidekick Tom wanted to talk about to the sex doctor and wanted to talk about sexual health. And so we went through the sex deck, almost card by card. Rhiannon listened to it, so she can tell you more about it, but it was great.
Yeah, it was insightful to see that these men, they both of the men have female partners, and they really took interest into what you were saying, and more in I need to be more mindful of that. Like, it was interesting to watch their demeanor, because it could have been crass. Like, it could have been just like, I think there was a couple of times when you're coming to, and it was
oh my gosh,
just a couple moments. But other than that, it was just these men really took interest into women's health and their partner's health, and I thought it was genius. So
they wanted to know how to talk to their kids about sex.
Yes,
that was what was really fascinating. We had a really good conversation about how to talk to your kids about sex, and so I really love that conversation, and hopefully it helped the guys and whatever. But I was honored to recently be on a podcast called The Paradox, and that was interesting to kind of share the story of True. Shelley Irwin honored me with having me on her Powerful Women podcast that was recent. And, it's just, again, I really believe in all boats rise. So if all of us, as we gain expertise, we share that and we help all of ourselves like rise. And again, if I don't know about you, but one of my values is legacy. And if I can create this company, this process, that goes on for years past me, what an amazing thing to be able to help women, not only day to day in our office, but, on a scale where just to empower women to, again, be in the driver's seat of their healthcare. So I really wish all of you the best. And as you were all popping in on the Zoom, I just got shivers, just to think that, isn't it incredible that we can come together around such a topic? We can talk about these things in public. And I really, really believe that it is possible. And if nothing else, please take some hope from, it's just to start a business in a pandemic, to leave a healthcare system and a comfortable job. It took so much courage to do this. So I just want to encourage you to know your why, know what you want to be, figure it out, and just let's all do it. It's possible.
We had one last question. I want to make sure I get this. Diana asked, no carbs after 4. Does that include veggies or simple carbs or all carbs?
So again, I hate rules that are all or none, right? But from a general rule, no carbs after 4. If it's most days, and if maybe weight loss is part of it, that part of what you want to accomplish. So again, toward the end of the day, anything we eat in terms of a simple carb. So I'm not talking vegetables, have all the veggies you want. So my favorite dinner would be a piece of fish and a salad and green beans and lots of water. On a special night, I might have salmon and a salad and a half a glass of wine. But most nights it's no carbs after 4, because for the end of the day, our cortisol goes down, our insulin goes up, and anything carb we eat goes straight to belly fat. So how's that? And Sugar Busters is that book that has some really good information about the glycemic index and gives a lot of science to that topic. So I highly recommend you check out Sugar Busters.
Awesome. Well, I really appreciate your time. Can we stop the screen share? I would love for everyone to just say thank you. I feel like take your mute off and just tell Dr. Bitner thank you.